All right, good day, everybody. Welcome. This is Jamie Litrun, along with Dr. Svante Berg and Christophe Stanic. We're here talking about Christophe's revision. So we're going to be talking about the two-level replacement he had with Dr. Berg with the Lp-ESP. Always try to hit subscribe. That way you can be one of the first people to see these videos. And secondly, always want to disclose, there is no disclosures. No one's getting paid. There's no financial perks. There's nothing being gained. Is always the goodness out of our hearts. Dr. Berg, Christophe, how you all doing today?
Fine.
We're fine. Yeah.
In Sweden, it's evening, and I have a sore back after days of farm work. But that's the only thing.
Oh.
So what were you doing on your farm today, by the way?
We were putting on fertilizers on what we planted this last autumn.
Okay. All right, good enough. So Christophe, we're going to just kind of go through a chronological order with you today, just to kind of give everybody the scenario, what happened, what went wrong, what's gone right, and kind of move on from there. And obviously, Dr. Berg's going to give his big points on this. Let everybody know how it was all done, how it was all achieved, and why, of course, why he did it. So Christophe, first, before you went to have your first surgery, what were your symptoms in your lumbar pain, and what made you look into artificial disc?
So before the first surgery, I had an accident. It was actually a dog bite. I fell flat. I flew in the air, fell flat on my spine. And so I had a fracture at L1. And a few months later, actually, I had like my neck broken and my lumbar. So it was actually a 5-level. And it was extremely painful. I couldn't function. I couldn't walk. And and it got worse and worse. And that's why I had the surgery. And that's basically what happened. And so the symptoms were, I had extreme pain all over my spine because actually the fracture at L1 created, the spine was kind of collapsing, and because I had this disc from like L4, L5, L5, S1 were completely, I will say, broken. So that's why I had surgery.
So why did you look? I'm sure you went to surgeons here in the United States, and then you looked at some of the options overseas. Why did you look more towards artificial disc? What made you go towards that direction?
Because they would actually fuse me 5 levels fused, and you don't want that. Can you imagine if you get 5-level fused? I don't know. It's you cannot move. You cannot. You don't have any motion in your spine. So that's really a problem. And artificial disc offers better outcome because you can move. You can get back to life. In a normal situation, if the surgery is successful.
So let's move on after your surgery, your first surgery. You started to notice that you weren't recovering maybe as well. When did you start to notice, say, in a time frame that you were having problems or there was an issue?
So it started at the beginning because I couldn't really bend. I had issues bending. So I told my surgeon that I couldn't bend very well. And he told me it will get better. So I waited months and months and months. And it was probably if I remember well, at 11 months post-op, I was having some pain. I think it was facet pain, or I don't know, but something wasn't going very well because I was just sitting on the floor with my dog, and I didn't do anything crazy like jumping and I got up and I had really bad pain. So I had to stay for 2 weeks in bed, and it didn't get better. I mean, it probably took 2 months to get better because because I had to fly to Europe, actually to France, and so I went to France after 2 weeks, and I was like, oh my God, this is not good because it's still painful. So it got better after 2 months, and I had it again by just sitting on the floor, and so it came back, and that's when I really noticed that something was wrong. And I don't know if you remember, you had someone on the group who actually made a Photoshop GIF with the flexion and extension. So it did it very well. So, and on the GIF, this kind of video, you could see that the disc wasn't moving. I mean, both discs. There was just a slight compression from the top, and the disc didn't have the center of motion it should have. So that's when I really noticed that things weren't working very well.
So at this point, I think you were pretty active in the group, and I think you were looking for solutions. So yeah. How many people did you talk to figure out where you wanted to go, you know, to kind of get this fixed? Who told you there was nothing wrong? I mean, I'm not looking for necessarily names, but
so many people told me there was nothing wrong. First on the group, like, I mean, you know, there are people who were on the group for years and years, like probably 5 years or a lot longer than I was on the group. So they told me to flatten my lumbar because they thought that the muscle was too short or something like. And but after that, I mean, I tried everything. I was like trying this like pelvic tilt exercise, and I did it every day, and I did some stretches, and like, so really everything, nothing worked. And after that, I started, I talked to my surgeon, the previous surgeon, and so I asked him what to do, what was the problem, and I didn't really get any answer because he ordered different tests, and I didn't believe this test will be useful because, I mean, it was a mechanical issue. It wasn't like a metal allergy, or it was nothing like that. So after I started contacting a few surgeons, and so I would say some surgeons didn't see anything, and but I contacted Dr. Ricard in Luxembourg and Dr. Berg, and so you two actually were the ones who actually told me there was something wrong, and so, but other surgeons, I don't really know if they didn't want to do it because it requires a lot of work. It's a lot of responsibility to do this kind of revision, and I don't know if other surgeons, I mean, can do it like that. I don't know. I'm like, because.
So was there conclusions both similar, Dr. Berg's and Dr. Ricard's?
Dr. Ricard, it was a little bit different, but I mean, just in terms of like, Dr. Ricard said that he will remove this disc, but he wasn't sure he could replace them by an ESP. So, and Dr. Berg was actually the only one who told me, okay, let's do it, come and we'll do it.
All right, so Dr. Berg, why, you know, in this community, especially your colleagues, you've raised a lot of eyebrows. Why, you know, it's true. I mean, we know this, that there's a lot of eyebrows being raised because in this group, I mean, you know, a lot of our patients that talk to surgeons throughout the world say, listen, you know, doing this is way too risky and there's too many risks involved. And we know that. I mean, it's definitely a risky surgery, and it definitely takes someone very talented to kind of even consider this. But why did you consider this, first of all, Dr. Berg?
Well, first of all, when I started to have mails and pictures sent from Christophe, it was obvious to me what was wrong with the processes he had, because they had locked in hyperextension, both of them. And that means that he had, prior to surgery, had absolutely healthy facets. And since this was just sometime more than a year, probably the facets would be healthy. They looked still healthy, but they send a lot of pain. They are very pain productive facet joints, and if they get under the wrong type of load and pressure, everything that Christophe told me about his pain fitted in well with that.
So you saw some degeneration in the facets over, what was about 13 months or so, 14 months when you saw those images?
Yeah.
No, they still looked healthy, but they produced pain.
Okay. So obviously, this was risky, and you knew how the M6s were placed. Like I said, why did you feel like, okay, this is something I want to do for Christophe? I mean, what's the nuts and bolts of it, I guess?
The normal thing in my type of world among surgeons is that you take care of your own mistakes and problems. But obviously, Christophe, nobody wanted to touch him. They said either they didn't understand his problem, or they said it was too risky and difficult. And actually, I felt pity for the guy, and I could see the problem. And I've been blessed. I've done discs since mid-90s, and I've been blessed with very, very few revisions. But on the other hand, before I started using discs, I did A-lifts on patients, and then they've had to come back with adjacent segment disease, some of them. So I've been in this type of mess with scar and everything before, and I was able to manage it together with a nice vascular and good vascular surgeon. So why not giving Christophe a chance?
That brings me to a good question for you, Dr. Berg. Why is it that a surgeon will go in and do, to your point, they'll go doing an A-lift at 2 levels, and then the 3, 4, for example, will begin to degenerate and cause pain, and they have no issue going in to do that level with an A-lift? Why is that?
Why they don't want to come back? I didn't get the question fully.
So for example, and I'm just making a scenario here. Patient A comes in, and it's not necessarily you I'm talking about. I'm talking about the colleagues or the U.S. surgeons or whoever we were talking about in general. They'll go in and they'll do an A-lift at 1 or 2 levels, and then obviously over time, depending on the patient is very young and active, and that level above begins to cause pain and cause issues, they have no problem to go do another A-lift at the above level. Is it just as easy, or because you're not going through the same access? Why is it they don't have a problem doing another level above, but they have a problem doing a revision? I guess that's my problem.
If you've done the 2 lowest levels, I mean, L4, L5 is always the most difficult levels, both on vascular and scarring.
Right.
And if you've done an A-lift on the 2 bottom ones, it's not that difficult to make 3, 4. Okay. But what I learned from my patients with A-lifts that I had to reoperate and add discs to them is be very strict on who I do A-lifts on. I try to save mobility on all patients to avoid adjacent segment disease.
Sure. So prior to Christophe, because we talked back in Le Mans, France, because I told you, there was a lot of patients in the group that had, M6 lumbar failures. And at that time you said, well, I'd probably do a posterior fusion. And I think that's the case for a couple people that are looking at that in our group. And that may be the best outcome. but is that the best solution, or is that just a way to stop the pain? What is your, you obviously changed a little bit on your thinking, because once you saw Christophe, you said, oh, I'm going to go ahead and do this revision. But like I said, I know, back when you were doing maybe a pro disc or the, I forget the other disc you were using all the time, but you would, if there was an issue, you would do posterior fusion. So is your mindset still on possibly doing both?
I think that the most frequent reason for my reoperating my old disc prosthesis patients, and that's a lot since I've done it for 25 years, and there's a lot of people that have been through it. And then there's a little percentage that would, with the mechanical discs that we had beforehand, develop facet joint arthritis. And probably I got your question when we met as a case that had developed facet joint arthritis, because then I think it's too late to shift out the disc to another disc. Then fusion is the only alternative. And a posterior fusion, where there's a disc there, it's easy, but you lose mobility, and that is the sacrifice. And as in Christophe's case, the facet joints were still healthy. And so I thought it was a pity to steal mobility from him.
The reason why I'm asking you these questions is for people that are concerned, because we know there's 50,000 people that have, M6 lumbars. So they, I think what I'm trying to do with this is create a solution. And a lot of times people may say, well, listen, I want to do what Christophe said. And I want you to have that answer for them, like you just did, on why they may not be a candidate. You know what I mean? That if there's facet arthritis, that may not be the best solution. But I guess one of the things that I worry about, and I knew that was going to be your answer, but one of the things that I worry about is, what if that M6 has already come apart? Because we knew that happens as well. There's some scoliosis cases where the M6, those strings, I mean, you know what it looks like and how they're built, that the strings are beginning to buckle or loosen, or that core is beginning to separate. I guess I'm looking at it as a safety concern. When you do posterior fusion, will that stop the disassembling of the M6 lumbar? You know what I mean? That's the fear.
And that is that's a delicate question, because since I never was appealed by the M6, I never implanted it. I've just taken it out. And where does an M6 that breaks down come to a limit where you cannot any longer preserve what's left of it by a posterior fusion? And in that case, if the facets are gone, you might have to make an A-lift to get rid of the stuff. And if the facets are healthy, I could do it like on Christophe.
Let me ask you this, because this is one thing I never understood too, and I know some of your colleagues that go to Gecko in France, they said that they would do a posterior fusion and then go through and fuse the M6, remove the core, but leave the plates in there. What I don't understand is, how would you remove the core and still be able to fuse those two vertebral lumbar bodies? Because the plates are obviously blocking the bone, right, or preserving the bone from touching. So how would they fuse?
You cannot make an anterior fusion with the plates in place. Maybe they take away the core just to know that it's not running around in the body, and make a posterior fusion.
And because,
with the plates there, you can never have an A-lift. Then you have to take the plates out.
Sure, and these are some of the people here. So that's, I said that when they're talking to their surgeons, I want to see I want to paint the picture as best as possible, right? For that way, they have a clear understanding of what their surgeons are talking about, because that was something I really never understood. But to your point, you're probably right. They're probably going to let those two plates just sit on top of each other and then do the posterior fusion. And then maybe at some point the bone could grow around the plates, possibly. You think that could happen?
Yeah, I think that must be something like that behind that thought, because the only reason for them to take out the core is because they are afraid of the core being left since it's breaking down.
Right.
And my experience with taking out M6 is limited because I always try to have patients with problems with M6s to address their original surgeon, but there are people approaching me that hasn't been provided any help from their original surgeon. So I'll probably do this again and again, but I don't want to be the garbage man for all spine surgeons. I think basically you should take responsibility for your own cases.
I agree, and I hate to laugh at it. But it's unfortunately true.
Not that I think you're garbage, Christophe.
No. I understand. Totally understand.
Good.
So, Christophe, let's talk about your trip into Sweden. You arrive, you get at the airport. What did you think of the hospital, the accommodations? Maria. Obviously, you met Maria and Dr. Berg for the first time. What did you think of the whole operation?
Before I left, I really didn't know what to expect. I have to be honest. I was like,
sure.
I'm going for a revision, so it's a big thing. So, I mean, the anesthesiologist was talking about like 6-7 hours surgery, and I was like, oh my God, that's... So I left. I was like, went to Sweden. I arrived, and I just found kindness everywhere. This was just an experience. It was just amazing. I mean, I'm not saying that because you are here, Dr. Berg, but I can compare 2 experiences before first surgery and the revision. And I can tell you that you are just so kind. Like, I was impressed. I was like, I didn't expect that because I was like, oh, I'm going for a surgery. And the way you take care of people, I mean, Maria, everyone, the nurses too, just amazing. I mean, I even got a massage and everything. It was like just super nice. Like, I mean, so, and the hospital is nice too. You have a beautiful, nice little cafeteria on the floor. So you can go there, just eat whatever you want. The room was super nice. So I was like really impressed. There was nothing that, there was no negative point, nothing like. So, and Dr. Berg is really caring. I mean, you even came with me to get some X-rays taken. So, I mean, I didn't expect all that, and I'm really thankful. I'm grateful for what you did for me. It's
so,
yep.
So I'm happy to hear it.
That is great news. I think a lot of people, obviously, firsthand experience, and that's what I'm trying to do, create firsthand experiences for people that kind of understand. So, Dr. Berg, when you, obviously knew Christophe was coming, and you talked to your access surgeon about this, did he give you the eyebrow or the stink eye, or how'd that conversation go?
I told him to have a heavy breakfast. I know I prepared him that it's gonna be a day, and exactly how long the day will be, we didn't know. But it makes me so happy to hear what you say about us. We are not just a spine factory. We love our patients, and you obviously noticed that, and that makes me so happy.
Yeah, and the access surgeon was great too. I mean, I talked to him by email, so yeah. I was like so thankful. I don't have any pain on my scar, nothing. Everything is like is perfect at this level. Yeah,
and both the access surgeon and me has to have a lot of patience. I mean, you cannot rush through this. You shouldn't have a train to catch. You just have to have an open day, because you never know how long it takes, and you're just gonna spend the time needed.
Yeah, you have to say that it took 9 hours. I mean, it's a long
Almost.
time. Yeah.
So, Dr. Berg, I'm just going to turn this over to you, and you want to talk about the surgery. And like I said, that's one thing that Christophe, obviously, a lot of patients have asked him, how much he knew of it, but, give us the whole procedure, the nuts and bolts, the access, removing, obviously, what you did to remove it. Was it difficult? Was it not difficult? Was there anything that came simple of it, or was it just really tedious? I guess that's what we're really looking to hear from you from.
Well, first, I mean, the incision is like any other incision where it's a scar. So it was, at that point, it was absolutely normal. Then coming into the abdomen, you go retroperitoneal, meaning that the peritoneum with all the intestine in, you leave that to the right. And since this was a 2-level case, there was the option to go to the right and leave the intestines to left wasn't a good option. And so we went down there and found massive scarring, and that is absolutely normal. Anybody would get a massive scarring after that type of procedure. There was, for a while, they tried to sell sheet that you would put in front of the vertebral, vertebrae to avoid adhesions. But since reoperations is extremely rare, and all the adhesions among the vessels would be there, I never used that, and I don't think it would have helped a lot in Christophe's case. Only when we already were past the vessels, it might have been smoother if there was a sheet there, but then we'd already done the difficult work. So it was time consuming, slowly working our way through this scar, because within this scarring, you're not supposed to find out what is a vessel by bleeding. You're supposed to find it out prior to bleeding. And especially the venous, they are very thin with low pressure. You cannot feel a pulse on them. Then you have to move extremely slowly to get there in a safe way. And as we did, I had, through your help, the implant tool of the M6. I put it on the discs and they were stuck, of course. It didn't give me a lot. It's meant to put the discs in, but not to take them out. So I have to use chisels to go between the end plates of the prosthesis to loosen it from bone. And since there was nothing wrong with the bone ingrowth, it really had taken place. And if I would just have roughly taken the end plates out, then I would have pulled a lot of bone together with it. But I wanted to have that bone left for the next prosthesis. So therefore I went with chisels between the end plate and the bone. And as when the prostheses were out, it's no cancellous bone more, because the bone ingrowth made it what we call spongious bone. That's more like a foam thing. And that is not as strong as the cancellous bone that is on the end plates from starters. But I was lucky because the prostheses were not put all the way to the PLL. So I could put the new prostheses a little further in where I usually want to have them, because the bone there was affected by bone ingrowth. It was at the posterior corners, it was as strong as in a primary case. And then I could have a good bone support, because most of the load is anyhow on the posterior part of the disc. Did that make any sense?
Completely. Let me ask you this, because you want to make sure that you leave more cortical bone behind cancellous, because cancellous is the spongy bone.
Yeah.
Okay.
Once you've had bone ingrowth, the cortical bone is changed to spongious bone.
Oh, I see. Okay. Mm-hmm. Yes, that's actually what you told me. I mean, after the surgery, that I had to be careful because it could, not collapse, but break some bone. No.
Yeah. So because this is not my normal surgery, so I didn't know how weakened were your vertebrae. Mm-hmm. After some time, they on a healthy person, bone always gets stronger where it's loaded. So
Yeah.
that was actually the first time after surgery I wanted Christophe to be careful, because I didn't know how much less load than normal would his end plates take.
Yep.
And how did his bone feel to you once you took those discs out? I mean, did it feel still, because it looked like he's got really good, strong, like bone, like his DEXA score would be really high, but that's just from the x-rays that I seen after. So was it really good?
Yeah, it was absolutely normal bone. The difference is that normally I clean the end plate very thoroughly out, and so there's no soft tissue, nothing that could make a disc migrate left. But then I stopped by the cancellous bone, and that is a little layer of condensed bone on top. And he was lacking that because he already had the bone ingrowth in the M6s. Yeah. Except at the posterior corners where I could use it.
Sure. And you didn't use any type of sheath or anything afterward, right, for him, for the scar tissue?
What if I used the...
You didn't use any kind of collagen or amnio sheath afterwards to prevent the scar tissue? No. Okay. I just wanted to clarify. So Christophe, you get out. How was your recovery? I guess let's talk about the first 5 days after recovery. Because I think that's one thing our patients need to realize too. Obviously, the pain is much higher going back in the second time. So you want to talk a little bit about that?
Yeah, I mean, right after the surgery, it was painful. I mean, I was, no, not right after. I mean, when I woke up, it was painless. I mean, I was even laughing. I told you, Dr. Berg, you were God, and I was like, wow, yes.
I remember.
Really, like, I was like, this is not possible. This is like, because the first time for the first surgery, I had so much pain. So, but the second time I was like, wow, is it going to stay like that? No, it didn't. I mean, of course, like the next few days, I had some pain. But I mean, if you want to talk about symptoms, I had sciatica for like, I'd say probably for a good 2 months. But like the first few days, yeah, it was pretty painful. I mean, Dr. Berg came to my room, and Dr. Berg actually makes you do the frog. So this helps a lot because you release the pressure, I guess. I don't know, he can probably explain better than I can. And so, but you have a lot of nerve pain because all the way to your toes, it was only on my left leg. And but the problem is my lumbar was stuck for about a year and a half. So I felt all these muscles, you know, all the nerves were firing, and so it was like it was pretty painful. So but it got better. I mean, after, I will say after 2 or I will say 3 weeks to a month, like it wasn't as painful. And but yeah, I mean, it's really a different kind of pain. Like the first time I had like no nerve pain at all, but it was more like painful on the muscles, but this time it was a different kind of pain. So it's very, like my leg was pretty painful.
So how soon did you start your therapy after surgery? Was it 12 hours, 24 hours? Do you remember?
We did the frog, I mean, right after Dr. Berg came.
1 hour after.
Yeah, and you made me walk, actually. I couldn't believe it. You know, I was like, I cannot walk because this was just crazy. I mean, I was like your little puppet, you know. You made me walk and to see if everything was going well, and like, so I was impressed. I was like, and and I didn't have any pain that day, you know, when you woke me up after the surgery, and I was like, wow, but it was great. I mean, the whole experience was
And
just.
then, how long were you in the hospital till you were discharged?
I stayed for about 9 days because it was a revision. So yeah, I was supposed to stay for like probably a week, but I stayed for 2 extra days because I didn't feel good. So
I think the sciatica was the extra problem for you for both then and for the first month at least.
Yep.
Since this type of surgery, you never touch those nerves, but you had been in hyperlordosis for so long, and suddenly that was removed, and that affects nerves a lot.
This was the problem, the sciatica.
Yeah, but to do a procedure like this, it's like being run over by a train. So I think you were courageous anyhow, and the thing is that if you get run over by a train, somebody can come and repair you. But in this case, after surgery, there's so much for the patients to do for themselves to get the best result. And so both me and Maria are very nagging people all the time.
Yeah.
Keep up.
So Christophe, you got discharged after 9 days, and then how soon did you leave Sweden after the 9 days?
I stayed for another week at the hotel, and so it was probably good. Yeah, a little bit more than 2 weeks, I guess. Like, yeah. And so, yeah, and I mean, as it was a revision, I needed someone to come get me, and so because I couldn't, it was difficult for me. I didn't want to take the risk to hold my luggage,
Sure.
Yep.
And one thing to tell the folks here, you went to France from Sweden. You didn't fly to the United States.
I stayed there for a few months, and yeah, like I would say 2 months, and after I flew to the US.
The reason why I mention that is if you would have left Sweden, would you have stayed longer in Sweden before you got on a plane to the United States, or would you?
Oh, yes, absolutely. I don't think you can fly after a big revision like that stay on a plane for 11 hours. It's tough. I mean, even the 2 hours on the plane, it was difficult. Yeah. So I will recommend, I mean, for people who have a first surgery, I would say maybe okay. It's probably okay to stay, but they should at least stay for 2 weeks, I guess, in Sweden and fly back. So that's wise, actually. Mm-hmm.
Yep.
Yeah.
May I ask you something, Christophe, since we don't talk every day? Can you sit on the floor and hug your dog now?
Oh yeah, I can, absolutely. I can do
Very
that.
good.
I have something to say that comparing the first surgery and the revision, like I feel that the surgery was done, the revision surgery was done super well, because the first time I had a lot of pain on the incision, and I mean a lot of other places too. And this time you did an amazing work, you know, because it feels right. I don't have any pain, and like on the incision and, you know, on my stomach. So it's very, very good. I can say it. Yeah.
Wonderful. Oh, you're gonna get that on the video.
Oh yeah.
Put the video on.
It's on. It's recording.
Oh, okay.
Say hi, Sunny. Say hi.
No, it was worth it to have his master on the floor.
Yeah, but she was very small at the time. She grew. She's big now.
There we go.
Good.
Well,
What a
fellas,
good life.
I thank you both so much for doing this. I know the group is gonna really enjoy this, especially with all the time we have at home. And secondly, everybody be safe, be
Yeah.
healthy, and you know, we're always here for you in the group, and we'll sign off. Thanks again, fellas.
Thank you very much.
Thank you, Dr. Berg.
Thank you.